Kind of an update in hyperbaric medicine as it relates to predominantly gas embolisms. Kind of get started. So we'll quickly go through a case and then discuss the pathophysiology of venous and arterial gas embolisms. And then go through some of the indications, contraindications, and side effects of hyperbaric therapy. Skip through some of this stuff. This is just about me and my love for diving. The cenotes, it's a very spectacular dive if you've ever been diving. I would highly recommend it. It's in the Yucatan Peninsula in Mexico. But my love for diving and the lungs brought me to a pulmonary critical care fellowship as well as a diving and hyperbaric fellowship. And that's our chamber at UCSD. And so this is actually a case that I saw, I think it was about 2 years ago at West Bloomfield. She was a 32-year-old female, diabetic, irritable bowel syndrome, and was giving birth there. She presented for delivery. An epidural was placed with loss of resistance, with reportedly using saline at about 8 centimeters. There's no obvious air injected per the notes, but immediately during the case, developed shortly after the epidural, developed diplopia, difficulty swallowing, confusion, and headache. It was a global kind of sensorium. It's so much so that she had trouble coordinating the contractions and getting the baby out. So they had to use a vacuum-assisted delivery. And so as soon as the baby was delivered, they activated the FAST team, and then they called the ICU for evaluation to see where this patient should go. On my exam, alert, awake, a little bit confused. The only real notable thing on findings was nystagmus and some patchy numbness in the legs. And we'll kind of scroll through some of the CT findings. It's pretty obvious. You can see patches of air throughout the cerebrum in multiple cuts, multiple different locations. And so they officially read the CT as free air within the basilar cysteines and the prepontine cystine, as well as tracking within the posterior fossa correlated with recent interventional puncturing of the thecal sac. So does anyone ponder what happened, or?
Air emboli.
Yeah, air emboli, yep. That's the predominant leading diagnosis, I would say. And so by the time I saw her, she was already getting better. But there are, and we'll discuss this, there are cases of symptoms occurring, a relapse interval where they have symptoms, get better, and then they relapse. And part of it is related to the inflammatory cascade that occurs during the introduction of air into the cerebral circulation. So I saw her, we put her on 100% oxygen, and then unfortunately had to refer her to DMC to get treated, where she had 2 treatments and had a very excellent outcome, no symptoms after the treatments, and the baby did well as well. So, I think this is timely, actually a timely lecture for this. I just got a call from some of our colleagues in the cardiology and cardiac anesthesia department. I guess I don't know if any of you were involved, but recently had a fatal case of gas embolism after a cardiac cath. So I think this is, I've had some calls from cardiology, ophthalmology about central retinal artery occlusion. There's clearly a need for more emergent therapies, and rather taking the time or the safety of transferring them out to DMC. I'm hopeful we can at least start doing emergency treatments in the next 6 months, at least starting during daytime hours, which is 7 to 7, the chamber's open, and kind of going from there. So embolism, just by definition, is a potential blockage. It's an object in motion that ultimately blocks blood flow, and can be multiple different things. We have air embolism, we have fatty embolism after your orthopedic surgeries, clots, pulmonary embolism, as well as a tumor. Arterial gas embolism occurs when air escapes the pulmonary circulation and becomes arterialized. It can also arise through the venous circulation with right to left shunts, PFOs, or any other structural or venous anomalies that allow the transit and bypassing the pulmonary filter. This is just a kind of overview example. You can see you can get the venous flow to arterialize through shunts. These are usually small bubbles but high quantity, or from pulmonary barotrauma where it enters directly from the lungs into the arterial circulation, which are usually small numbers but much bigger bubbles. Just a rudimentary sketch of our body and the circulation. And you can see, just kind of following through here, you can develop bubbles that arterialize, leaving the pulmonary circulation and into the left side of the heart and out. Or you can develop venous bubbles, and we'll discuss where these venous bubbles come from, which usually get filtered by the lung, but sometimes they can overcome the filter of the lung and escape. So the incidence of venous gas embolism is largely unknown. It's most of the time can be subclinical and usually is underreported. It can be related to direct insufflation or inoculation or injections from different procedures. Also as a consequence of your surgical interventions where you have an open vascular bed that's open to the air. So you have multiple causes of the ability of air to enter your the circulation. These are all your surgical procedures. The most high risk of these is your neurosurgical interventions and your cranies. You can see when they come back from surgery, they often have a lot of gas right under the skull where they did the surgery. It's usually because they're sitting upright. You have an open bed of uncompressed vessels, as it's up here versus to the level of the heart, so everything drains down. Versus when you do your central lines, you keep them on a flat to a little bit of head down position to create a little bit of positive pressure where you're puncturing. To minimize the entry of air into the circulation. So it's usually your head and neck surgeries, your cabbages, your bypass surgeries, hip replacements, some of the endoscopies. If you notice when they come back, they have so much air insufflated, you can even feel crepitus sometimes in their limbs. Traumas, blast injuries, inhalation of peroxide, ingestion of peroxide or inhalation of helium right from the canisters. And even during orogenital sex or vaginal deliveries. These are your causes of non-operative gas embolisms. We have a lot of them due to diving, of course. These are when you have your breath hold ascents against the closed glottis. You have your undiagnosed or unknown pulmonary lesions, obstructive lesions. They did a lot of studies when in the 40s and 50s when were doing submarine escapes for your people in the Navy. Of course, more hospital-related, central line placements, dialysis catheter placements, dialysis itself, the CT power injector, mechanical ventilation, and therapeutic vaginal surgeries. So the consequences, if a lot of these are underreported, it's largely you become symptomatic depending on the volume of the gas and the rate of entry. Usually the lungs filter out a lot of the bubbles that are introduced into circulation. They can filter up to 22 micron sized bubbles, but they found in at least animal studies that if you inject over 30 cc's of air, that's enough to overcome the pulmonary circulation and then arterialize. They've estimated in humans that about 200 to 300 cc's of gas can be lethal. Part of it occurs as basically creates a vapor lock on the right side of your heart. As you get bubbles that clog the pulmonary filter, it increases your pulmonary artery pressures, decreases your venous return to the left side of the heart, decreases your cardiac output, and causes a cascade of events. This is just some pictures of divers who've suffered gas embolisms. You can see lack of air markings on the left side, as well as air filling basically the heart. And I believe this is part of the venous circulation there. And others, you can see both the arteries and the veins exiting the arm, filling with air. And again, a lot of air here. Unfortunately, all of these patients expired. So usually the treatment of, I think they only use 10 cc's of air, if one syringe, if anything. So it's enough to visualize, but I guess in theory not enough to cause damage. But good question. The treatment of it probably falls under your underreported or subclinical venous gas embolisms.
That's why, just to keep in mind, so it's true they use just a really small amount, but that's why the cardiology will get pushback often if the patient's already had a bubble study and we've seen what we need to see on it. They will call and not want to do that part of the test if it's unnecessary, because there's always the theoretical risk that there could be problems.
Treatment of VGE is largely supportive. Depending on the degree of bubbles insufflated and the status of the patient, 100% oxygen is the mainstay, and then supportive care, intubation, CPR, inotropic support for the right side of the heart if needed, and placing the left lateral of the cubitus. There's theory that the bubbles will rise and kind of come out of the RV outflow tract to allow things to circulate. There's anecdotal evidence of direct aspiration of air out of the RV, either pushing further your central venous catheter into the heart or even direct aspiration, as well as hyperbaric oxygen. But a lot of this is, there's unfortunately not enough studies and no definitive evidence for the use of either of those treatments. So this leads to looking at the other side of gas embolism, is direct introduction from the alveoli into the arterial circulation. And I believe they did the study in fresh cadavers where they only required about 60 to 80 millimeters of mercury to rupture the alveoli and introduce air into the circulation. That translates to as little as 4 feet of seawater. We've even had divers come in San Diego where they're doing their open water course. They take a puff of compressed gas at 10 feet in the pool. They hold their breath on the way up. That's enough to cause gas embolism and subsequent loss of consciousness and problems from that. So I mean, technically all it takes is about 4 feet of seawater and that change in the water column. So once the alveolar membranes rupture, about 30% of it typically goes into the mediastinum. It travels the path of least resistance. The rest can arterialize, and the problems occur once they start to occlude. So they basically cause, like your coronary ischemia, plaque rupture, occlusive hold within the circulation. But there's also damage. These bubbles are very toxic to the endothelium. It activates the platelets, and the endothelium is activated and causes an inflammatory cascade where the leukocytes, platelets start to adhere and cause vasogenic edema and such. So, just a pictorial example. So, risk factors for pulmonary barotrauma. Of course, your obstructive lung diseases, COPD, asthma, any structural lung diseases, bullae or cysts, where air can potentially get trapped within there. And this plays a role for both hyperbarics as well as diving. If you have trapped air that's not escaping and it begins to expand, of course, you have a risk for rupturing your alveoli. Certain restrictive lung diseases as well, adhesion, sarcoid. If you start to tether some healthy lung to the wall, that can differentially expand and rip the alveoli. Sarcoid in and of itself also has endobronchial lesions, so you can in theory develop kind of a ball valve phenomena, and air can fill but not escape quickly enough, and hence you get expansion. Recurrent lung infections, tuberculosis, and a low MEF25. When they've looked at pulmonary barotrauma and HBO, they did a study looking at 98 centers worldwide. They found about 9 cases out of 2 million. So it's very, very rare. But in almost all of those cases, the patients were asymptomatic from a lung standpoint. They were treated, but on retrospect, after the event, they were found to have pulmonary pathology, whether it was cysts, sarcoid, etc. And so today, there's no formal guidelines as far as screening for HBO. But here at HBO, Henry Ford will do screening x-rays as well as spirometry with bronchodilation just to help ferret out any underlying lung pathology as well as any people with reactive airways. So when people present with gas embolism, they can present with immediate death, less than 5% of the cases occurring with immediate apnea, unconsciousness, and cardiac arrest. Typically, these, because it's arterialized bubbles, symptoms are very, very quick. They occur within 10 minutes of surfacing or 10 minutes of the inciting event. And you have varying neurologic symptoms depending on where the bubbles block in the cerebral circulation. So this is usually life-threatening and requires immediate attention. And in the diving population, it occurs in about 7 out of 100,000 divers, or about 100 cases per year. So rare, but again, these low-volume, high-risk events. Typically, a majority of the patients suffer a loss of consciousness at the time of the event. And then again, depending on where the bubbles hit the cerebral circulation, you can have anything from paresthesias to frank paralysis, visual changes, confusion, ataxia, seizure. If there's associated pulmonary barotrauma, chest pain, shortness of breath, and cardiac arrest. In the water column, typically 40% of the symptoms will occur on your way out or within 5 to 10 minutes of reaching the surface. So in looking for AGE, again, looking for signs of barotrauma, crepitus, external trauma, and doing your full neurologic exam. Is X-ray or CT MRI helpful? Not always. This study by Harker in '93, they looked at 31 patients with gas embolism. They only found about 40 to 50% of people with any kind of lung abnormalities or pathology. So the absence, so if you don't see barotrauma, it doesn't necessarily exclude gas embolism. Some of these had infiltrates, again, just from local injury, alveolar injury. And then CT, MRI, again, not useful initially. There's this phenomenon of gas embolism, of symptom relapse during gas embolisms. You can have temporary resolution followed by relapse. It's first thought to be secondary to bubble regrowth, but as they've studied this more, it's more, they think, related to developing or worsening cerebral edema. Again, related to the endothelial damage, platelet aggregation, and the inflammatory cascade of ischemia reperfusion. Just another pictorial example. If you have ischemia as the bubbles clot off or kind of prevent flow distally, causing cellular injury, vasogenic edema, and inflammation. Again, mediated by your leukocytes and platelets. This is just a pictograph of the varying causes of the symptoms of once you develop pulmonary barotrauma. Again, you get the local alveolar hemorrhage and hemoptysis, extravascular air, either leading to pneumothorax or your mediastinal subacute emphysemas, and then arterialization, either to the coronary or cerebral emboli. Unless treated promptly, again, with recompression, it can result in permanent sequelae. Again, this is somewhat related to the diving population. So you need a high index of suspicion to make this diagnosis. Again, there's no specific test, so you just need to have it on your radar. They've seen non-diagnostic elevations of the LDH, lactate, creatinine kinase, ALT, AST. It's just indicative of widespread gas bubbles affecting the multiple of organs. Hemoconcentration is very uncommon and does correlate with with neurologic outcome, and then elevated CK, which peaks at about 15 hours post-injury, is one marker that they found related to gas embolism. And here they did a study, Dr. Newman at San Diego, looking at divers, trauma controls, and those with gas embolism, again, peaking CK levels at 15 hours of about 17,000. So why does HBO work for gas embolism? Again, it's a mechanical effect. You're crushing or compressing those bubbles, allowing them to release from the cerebral circulation, and you get blood flow. You create a diffusion gradient, just like treating your pneumothoraces. You're creating a 100% oxygen gradient to reabsorb the nitrogen that's in the air bubbles. Air is about 78, 79% nitrogen. It can reduce cerebral edema, augment oxygenation in your ischemic penumbra, and it helps mitigate the ischemia reperfusion response or decrease leukocyte adherence to the injured endothelium. Treatments, initially they recommended us US Navy 6A, and we'll kind of go through some of this, but the 6A is basically where they take you down to about 165 feet to very mechanically crush those bubbles. That's efficacious, probably more in the hospital setting, where if you can catch it within 30 minutes, you have better efficacy at crushing those bubbles. Anything beyond that, they say that just from natural oxygenation and circulation, your bubbles will start to shrink, and so the benefit of that 165-foot press is not as, the risk benefit is weighs more on the risk side, because it's a little tricky to take them down to 165. And once, if you have, after the initial treatment, if you still have persistent symptoms, we can treat you with further HBO. And this is just an example of what's called a Navy table, treatment table 6. We pressurized to 60 feet of seawater for about 60 minutes of oxygen with intermittent air intervals of 5 minutes. Slowly bring you up at 1 foot per minute to 30 feet, where you spend the next probably about 2 to 3 hours there. The treatment total in time is about 4.5 hours, 285 minutes. This is in contrast to a 6A, which you get pressed to 165 feet, about 30 minutes, and then brought up to 60 feet, where you basically complete the rest of the the former table. So treatment is usually the best bang for your buck will be in that first 6 hours, but there have been benefits as far out as 24 hours later. There's unfortunately no controlled trials of HBO versus non-HBO for gas embolism, but just looking at the physiologic rationale and the alternative treatment are very minimal. HBO is a reasonable recommendation. And you can see that in some of these people with gas embolism, they get very, very sick. They can be intubated on pressors, etc. This is a picture of the UCSD chamber, and you need a lot of stuff just to get your dives going. Tubing, syringes, you have your pneumo kit in case there's an undiagnosed pneumothorax or you develop one at depth. Your ventilator rated to work at pressure, all your oxygen tubing, etc. Your pumps. Virginia Mason, they have their own specific checklist for critical care with all of their critical care equipment there. Unfortunately, we don't have any of this equipment yet here. I think that's my first step, is getting the equipment so that we can run ICU dives. And again, it's tough to run critical care. You need staff that are comfortable managing both ICU and working in a hyperbaric environment. You need your equipment. It's like a diving watch. You just take your regular old watch down to depth, you'll break it. So you need ventilators and pumps and tubing just to work at depth. You have ventilator limitations. Some of the ventilators out there only can give you a minute ventilation up to 12 liters per minute, or a PEEP of 10. And usually you have to compensate for being at depth, and you deliver volumes about 1 to 1.2 liters, where it only correlates to about 500 to 600 cc's, depending on where you are in the water column. There are some people who require a transient increase or transient hypoxemia post HBO for a few hours. And in your really sick patients with HBO, I usually don't treat them if they're on more than 40% FiO2 continuously, like on the ventilator, just because the risk of pulmonary O2 toxicity increases. It's a very additive effect. All right, so very quickly, just getting back to the definition of HBO, it's the application of 100% oxygen when in an increased atmospheric pressure. Technically, by definition, you have to press the chambers to at least 1.4 atmospheres. It's probably about 10 to 15 feet of seawater. This is an example of a multi-place chamber where you have multiple people sitting in the chamber. You can see they're breathing oxygen through varying devices, either a hood or your like a fighter pilot's mask, your bibs mask. Here you have an inside tender who can help and examine the patients during the treatments. He is not wearing any oxygen. He's treated as basically as a diver. You have your monoplace chambers. Fits mono, one person. And you can communicate with the people through a microphone or through a little handset. And even this is hyperbaric. So this is animal chambers where they're doing animal studies. They have horse chambers as well. It's very popular in the equine population. I mean, those are million-dollar animals that they're trying to provide some bang for their buck to help keep them well post their races. Unfortunately, this is not hyperbaric oxygen. Topical HBO therapy has been debunked. Unless we're like frogs and you can absorb oxygen through your skin, this is not beneficial. So we are battling a lot of the propaganda and paparazzi out there. Amazing new oxygen, unclogs arteries, and allergies beats migraine. So right now HBO is not approved for any of these injuries. Brain injuries, cerebral palsy, stroke, chronic fatigue, multiple sclerosis, or as an anti-aging effect. We are, one of our hyperbaric colleagues in Minnesota just got a multi-million-dollar grant to look for acute traumatic brain injury. So that's kind of new. They've been looking at brain injury for acute effects and also for the veterans coming back from the war. Unfortunately, at least for the veteran population, has not, so more of the chronic has not panned out, but we're hopeful that maybe with acute TBI, this might be something down the pipeline. Just as a fun little background for HBO, I know we're kind of running out of time. It's been around since at least the 1600s for a very, very long time. But it really took off probably in the 1800s when they started to search for more mineral resources to help provide the fuel for the Industrial Revolution. They found a lot of them were underwater at depth, and so they built these caissons, 5-foot steel ring diameters in a sealed shaft to allow the workers to work at depth. And so to keep water out of there, obviously you need to create a pressurized environment. And so it's basically these guys are working 45, 50 feet under seawater. The rates of decompression sickness in the late 1800s was up to about 25% of these workers coming out of the caissons. And then someone had the brilliant idea of putting a recompression chamber on site and reduced the mortality about 1%. And just an example of the working environment of these, the caissons workers or the sandhogs. So around that time, the Grecian bend was a popular fashion. You can see that they were kind of corseted and leaning forward as part of the fashion at that time. They noticed that a lot of the caisson workers coming out of these compressed environments kind of looked like this, and so they nicknamed decompression sickness. This is where the nickname the bends came about. And what's in the 50s, Dr. Baramia, a cardiothoracic surgeon from the Netherlands, came up with this. I showed this last time. It's just a very interesting study where they did a porcine study where they removed, basically transfused all the blood out of these little piglets, and basically put them in with plasma or a lactated ringers type solution. So basically these pigs had no red blood cells, yet they were able to survive for about, I think they were in there for about 45, 50 minutes at 3 atmospheres breathing 100% oxygen. And then they all got the blood back, they survived, and they continued on their merry way. And this is the pathophysiology behind it. You need about 6% oxygen by volume just to maintain normal metabolism. Once your hemoglobin is saturated, that's it. I mean, you're 100% saturated. You can't saturate your hemoglobin anymore, but you can saturate the plasma. And it's based on your dissolved oxygen equation. Your hemoglobin, once you're saturated, but you can saturate your plasma here. And so at sea level, when you breathe 100% oxygen, you're basically saturating this number, turns out to be about 0.3%. If you do the calculations at 3 atmospheres with 100% oxygen, it actually equivalates to the 6% by volume to maintain metabolic functions. So indications for HBO, again, decompression sickness and gas embolism. For most all other indications, which are here, it's more of an adjunctive therapy. I'm hoping that as I acquire the equipment and the needed manpower and resources, we can start doing things here. I mean, over the past year, I've had a few CO poisonings come in that I've had to refer out to DMC. Ophthalmology's been calling about CRAO, or the central retinal artery occlusions. And again, I just got a call about gas embolism. So I think if we can start to build some of the, get the necessary resources, we can start treating these things. I tried to do an exercising soft tissue infection neck fash a couple months ago in the SICU. Oh man, just to get them out of the SICU, the patient was not on pressors, only on 3 liters nasal cannula, going in and out of surgery. But to get them out of the ICU into the chamber, they wouldn't allow it just because I didn't have the monitoring equipment. So, because right now they'd be unmonitored in the chamber for about 2 to 3 hours. So I'm hoping we can start to expand the services that HBO can offer. And of course, the past year I've been treating a lot of these diabetic foot ulcers, radiation wounds, chronic osteo, and employing it for limb salvage. Just very quickly, how does it work? You can mechanically crush these bubbles. You create an improved diffusion gradient with 100% oxygen and increased delivery to tissues, as well as some biochemical effects. It's we'll kind of skim through some of this. One of the, and it also creates angiogenesis, which is, this is a study by Dr. Marks. He's a head and neck surgeon looking at radiated tissue of the head and neck for cancer. They found when he measured the oxygen tensions in the jaws of these people who have been irradiated, he's found that he's measured the tension at about 30% of what it should be. And that by treatment, about 20 or so, when he remeasured, you can see he built the angiogenesis or the capillary bed back up to about 80% of predicted, which helps, again, these people who've suffered irradiation, helps them heal their wounds. Again, and they found that when you press people to 3 atmospheres, it helps halt the production of the alpha toxin associated with gas gangrene. This is as it relates to carbon monoxide poisoning, and decreases edema through vasoconstriction, but it doesn't impair oxygenation of those tissues because you can still maintain the perfusion in your plasma that circulates to the affected area. And again, it attenuates your reperfusion injury. It also helps your macrophages work. I mean, everything works better in a hyperbaric environment. The macrophages, the fibroblasts that help with wound healing, increases your neutrophils and oxidative killing of organisms, and your angiogenesis. And we've done this for problem wounds because this is the bulk of hyperbarics, is your wounds. Just because these problem wounds, these diabetics who have wound problems, multiple hospitalizations, multiple surgical procedures, significant disability, high morbidity, and they become very costly. A lot of these chronic wounds are known to be hypoxic. If you measure the chronic, the oxygen tensions in your wound healing bed, it's typically less than 20, compared to 30 to 50 in your healthy controls. Once you have a hypoxic environment, again, everything works worse. The neutrophils don't work, your fibroblasts don't work, you can't build the collagen to help with wound healing, and you have impaired capillary growth. And that's your rationale for HBO, and this is just some pictures of HBO as it's helping this diabetic heel ulcer. About 40 treatments later. It helps with, again, what Dr. Marks studied, your osteoradionecrosis. You can see exposed bone here. And building that angiogenesis and building that capillary bed. Radiation cystitis, radiation proctitis, neck fat, or the gas gangrene, helping save flaps. And some of the complications you worry about are, again, things related to pressure, things related to oxygen. Pressure changes, remember your middle ear and your sinuses. You can develop barotrauma. I'd say about 5% of the patients who come to hyperbarics, I have to put pressure equalization or PE tubes in them. Sometimes sinus barotrauma, claustrophobia. This is one of the cases of reversible myopia in patients. The oxygen deposits into the lens of the eye, causes a shape change, and changes your distance vision. And seizures occur about 1 in 3,000. Some of the absolute contraindications, basically, essentially just untreated pneumo. And some of these meds can exacerbate underlying wound problems. Just very quickly, there's about 500 centers across the U.S. You have your monoplaces versus your multiplaces. Animal chambers. And now we're running out of time. This is just the state of affairs in West Bloomfield or in the southeast Detroit area. All the red dots are wound care centers with hyperbaric chambers. I would say probably DMC down at 15 is the only 24/7 chamber. Most of these are 8 to 5s across the county. Dr. Eichenhorn founded the chamber in '88. He's been running it pretty much ever since. And this is our chamber here. It's located in the respiratory department, right next to them. So in the basement of the F building. Right now we only have 1 chair, so we're doing just single treatments at the time, so it's basically like a big monoplace. And our usual treatments are what's called the treatment table 9. We press the patients about 45 feet. You have 30-minute oxygen periods separated by 5-minute intervals, so total time is about 100 minutes. Again, future directions, acute TBI, looking at ways to mitigate ischemia reperfusion injury, and for us here, at least getting the equipment needed to help start doing emergent treatments. And these are just my mentors back at UCSD, and as well as Dr. Eichenhorn.
I have a question. I'm trying to understand. So when the patient is intubated,
Yep.
how do you treat the air like patients intubated in the vent? Like how are you giving the hyperbaric?